Um, so I think many of you know me from my work in quality and safety here in the Department of Physical Medicine and Rehabilitation. But in addition to that, I'm also the co-director for the Activity Mobility Promotion Program here, which is um, a program where we're really focused on addressing patients' function and functional impairments, particularly when they're in the hospital. So today, what I wanted to talk about is this whole concept of setting patient mobility goals, and also some of the barriers, in particular related to falls in the hospital. This is actually sort of a novel talk that I'm giving. So I really welcome any feedback if you want to give it to me offline, because I do plan on giving talks in the upcoming months in different areas. So please, I kind of am taking this opportunity also to kind of show some new stuff and would appreciate any feedback. So just to start off with, in terms of disclosures, I do provide some consultation services which are not relevant. So I'll skip that. And then for our objectives. So we're going to discuss our approach to measuring patient mobility in the hospital setting. I'm going to be talking about the concept of patient mobility goals that are based on their individual capacity. I'm going to be talking about how we're using this data that's being collected in routine care to understand this concept of the tension between fall prevention and patient mobility as well, which is a pretty hot topic. And then we'll be discussing the use of this individualized mobility goals to overcome barriers and some of our strategies for that. So that's going to be sort of the map of today's talk. But just to start off with, I just wanted to just talk just briefly about AMP. AMP is actually a pretty big program here at Johns Hopkins. It's, I would say in quick summary, it's an interprofessional program. We support hospitals, unit staffs, and providers. Really, the goal is to change culture of patient immobility, and we provide tools and support resources to design and implement structured quality improvement. And it sort of has these different areas related to addressing barriers, sustainability and engaging clinicians, functional measures in the hospital, quality improvement, patient engagement, as well as using data for culture change. Really the areas that I'm going to be talking about in this talk really have to do with our research work, as well as some of the tools and resources that are relevant for AMP. And perhaps maybe some of you guys have also attended our conferences. We're going to be presenting at the upcoming ICU Rehabilitation Conference, and I see Dr. Dale Needham joining here, as well as in the spring as well. So let me just start with the typical patient story. This might be a patient that you can relate to. This may be, your grandparents, or parents, for that matter, where, at their baseline, they're often pretty mobile. They might be pretty independent. And then what happens is that patients, and this is a story that happens, is very common, is they spend most of their time in bed in the hospital setting. And the result of that is that throughout the hospitalization, particularly if they're in the hospital for at least a few days, and especially if they're elderly, for example, or they have other comorbidities and so forth, that they experience pretty significant functional decline. And this functional decline is associated with lots of clinical complications, poor outcomes, et cetera. And this is really at a central core of what we're trying to address in our AMP, or Activity Mobility Promotion Program. This, just to kind of highlight this with like a recent paper that was just published this summer, this was a study. It was in about 21 patients, patients who were initially in the ICU. What they did is they put a little activity tracker. In this case, they used this device called the Tractivity. And they measured the mean or the average number of daily steps during the 3 days prior to ICU discharge. And then they measured it 3 days prior to hospital discharge. And then they measured it for the first few days after hospital discharge, and then 4 to 6 days. So they measured it, they averaged it at those different time points across all the patients. And this is what they showed. So the first two bar graphs, so the y-axis is showing their activity levels or steps per day. You can see that they have pretty low mobility in the ICU and right before hospital discharge. And then there's this dramatic jump from home day 1 to day 3. And so the question, the discussion of the paper is like, did these patients make this dramatic recovery when they went home? Or, is there something, is this just kind of highlighting, again, this kind of culture of the hospital that patients probably have the capability to be more mobile, but we're doing things, or the way the environment is set up and so forth, that patients aren't really that active. So anyway, this is just another example of showing how little activity kind of compare, for example, to home that patients are participating in. And we like to use this term, the immobility harm, because really mobility is related to all these different clinical outcomes that the hospital really cares about. So things like falls, readmissions, DVTs, pressure injuries, delirium, surgical outcomes, discharge disposition. If we want to address all of these different outcomes, we really need to be thinking about patient activity and mobility. And for this talk, what I'm going to in particularly be focusing on is falls. Now, how do we do this? So a lot of times in clinical care, there's been recommendations that have been provided. So for example, patients with heart failure, they need to be on a beta blocker. If you're going to go see a patient in the room, you need to be washing your hands. And there's a lot of science that goes behind that. But often what we find is that the science doesn't always translate into clinical practice. And so there's different models of quality improvement or implementation science that have been developed to try to execute this. And this is one, it's called the TRIP model, that was actually developed out of the Armstrong Institute of Quality and Safety here at Johns Hopkins, that has these key components, including aspects, for example, putting it within the context of the problem within the context of the institution, summarizing evidence, addressing barriers, measurement, and then at the local level, doing a cyclical process of engaging staff, education, execution, and evaluation. For this talk, I'm not gonna really be going into the full TRIP model, but what I did want to focus on is the measurement component. And why that's particularly important for quality of improvement. There's a well-known saying in quality improvement that without measurement, you can't do QI. And part of the reason also if we're thinking about patient function is that I think the ideal way is that we really want to be thinking about mobility and activity as a vital sign, like as if it was blood pressure, for example. We want to be able to track that over time. We want to be able to see variance from what what our goals are and so forth. And then the other concept too is that data drives culture. So being able to, for example, give feedback to clinicians who are working directly with patients, creating accountability and things like that. Those are important components of culture, and data is a critical aspect of that. So how do we measure function in the hospital? And there's definitely lots of different measures. For those who are therapists, for example, for assessing, balance, there's lots of different measures. But just from like a global perspective of what we're trying to really do or measure for all patients in the hospital setting, we think about kind of two concepts. And we think that really provides an important signal in terms of understanding about patients' overall function and their activities and so forth. So the first concept is the idea of capacity, and that's how much help does the patient require to do a particular task? Are they independent doing a task? Do they need the assistance of two people to do a task? Something like that. And one concept that's important to keep in mind is that somebody might be capable of being mobile, but they may not actually do that. If you think of yourself, for example, going to the gym, you might be capable of doing 10 push-ups, but if you're just not feeling it that day or for whatever reason, you may not actually do that. So the amount performed is the actual performance, and we use a different measure for that. And that's sort of the idea of how much over time did you do? Did you achieve some type of mobility milestone? For example, were you able to walk outside of your room, or something that could be measured, let's say with a device like a Fitbit, for example, like how many steps did you walk today? So that's an example of performance. So the tools that we use here at Johns Hopkins, the first one, which we've actually been using for a number of years now, is called the Johns Hopkins Highest Level of Mobility. It was actually developed off of ICU scale, but it's an ordinal scale that goes from 1 to 8, and it essentially has these different milestones. So there's different levels of bed activity and kind of progression with that. Then it's this idea of kind of transferring, for example, to a chair or to a commode. And then doing a more upright position of standing, and then we have different distances of ambulation, and these are based on key milestones that are based on the literature. So it goes from 1 through 8, and what we found is that the scale is very easy to use and educate staff. It records, again, what the patients actually do. The standard of care that we use, for example, both at Johns Hopkins Hospital and across the system that we advocate for, is that nurses document this twice daily and on each visit for physical therapy and occupational therapy. And kind of going back to that point that I was mentioning before about using this as a vital sign, this is actually when we first initiated or used this tool into clinical practice, this was one of our early quality improvement projects. This is an example of a patient who is actually developing critical cervical in their neck, their stenosis, and actually developing weakness. And you can see that they came to the hospital, they are able to walk about 10 steps, and then over time, you could see that their mobility level was going down, and this patient ultimately ended up needing surgery. So again, kind of towards that goal of using mobility as a vital sign, that gets towards that. So that's performance. Now, in terms of capacity, the tool that, and many of you are probably very familiar with this, is the AMPAC tool, but just, in brief explanation, essentially what it does is it asks how much help from another person does the patient require for these kind of 6 key tasks that are relevant for the hospital setting. Things like moving from lying on your back to sitting, standing up from a chair, walking in the hospital room. And this can be done both by patient report, also by clinician proxy. So it's not a performance test. You can actually, it's more of an assessment. And you essentially, on all of these questions, you ask or you assess how much help from another person does that patient require. Do they need total assistance, all the way to the fact that the patient is completely independent with doing that task. And the frequency that we recommend within the health system is that nurses are doing this once daily, and that physical therapy is doing this on each visit. And I just put a little asterisk by this because I am focused on basic mobility, but I also want to recognize that there is an AMPAC activity scale that's also being done by nurses as well as occupational therapists. But for the purposes of this talk, I'm going to just be focusing on the mobility aspect. So maybe some of you are familiar, but these 2 tools, the highest level of mobility and the AMPAC, are actually tracked in Epic. And this is actually a screen, and you can see, sort of in that vision of as a vital sign. This is an example of a patient, which I'll talk about in a little bit. And when we have worked with nursing, because nurses have been really, although AMP is, like as I mentioned before, is an interprofessional, multidisciplinary approach to really promoting mobility, nurses play a really key part of that. And so we've done studies to really look at the psychometrics in terms of, can nurses really do this well? And so one of the first studies that we published, this is a few years back now, we had nurses going into patients' rooms. We had therapists observing those mobility sessions, and we were interested in looking at the test-retest and inter-rater reliability. We found that that the psychometrics were excellent. We also had nurses comparing the AMPAC and HLM score, or the JH-HLM scores, with other validated metrics such as the grip strength, CATS ADL, 2-minute walk test, and the 5 times sit to stand. And so all those other measures have been recognized as measures of physical functioning, and we were able to show strong construct validity with reasonable correlations, suggesting that these measures also do measure various aspects of physical functioning. So in brief summary, what we did find is that there was strong agreement between nurses and physical therapists, at least when the physical therapist was an observer in terms of these tools, and that JHHLM and AMPAC are reliable and valid measures of patient function when scored by nursing. We've actually conducted a recent study to sort of further develop this idea. So we actually had nurses and physical therapists independently go in and mobilize patients on the same day at different times of the day. We did this on 42 patients in a surgical patient population. That study that I just showed you was in a neuroscience population. This is in a surgical patient population, just to make sure that our conclusions are also generalizable to different patient populations. And this is what's called a bland Altman plot. And basically, the way to interpret this, and I think the key is, if you look at the y-axis, what we're looking at are the differences of scores between nurses and physical therapists. So if they had perfect agreement, then their HLM scores would be the same, and basically it would go on that red line that's depicted on this graph. On the x-axis, we average the two HLM scores, and what you can see in this graph, this light gray line shows sort of the overall mean differences between nurses and physical therapists. And so the fact that the line is just slightly below zero just means that on average, the physical therapists are just mobilizing the patients to a slightly higher level than nurses do in this small study. But I think what's also important to recognize is that particularly when we're thinking about kind of higher mobility levels, like when we're thinking about ambulation, so which I'm circling in that dark red line, is that actually the nurses are able to achieve the same or even higher HLM levels for patients who had less impairment. So you can see that they were able to reach those HLM levels of 7, 8, and sometimes even exceed the therapist by a level. But probably in those patients that have a lot more impairments, where I kind of circle it in that orange graph, we see that the therapists are we see that like -1 mark difference between the nurse and the physical therapist, suggesting that the physical therapists are mobilizing those levels a little higher. So this is, again, but important, background and sort of data to suggest that nurses can, for the most part, mobilize patients pretty similarly to our what we would consider gold standard therapists. Okay, so now that we have, I've sort of explained our tools and hopefully, convinced you that nurses, for example, can record these tools pretty well. I wanted to show an example of how we're using these types of measures to address this real issue that affects patients on a regular basis. And the topic that I'm going to be talking about is the tension between mobility and falls. So this paper actually was published in JAMA Internal Medicine in 2017. You can see the senior author is Sharon Inoue, who's considered she's really well recognized for her research and clinician in the field of geriatrics, and basically they wrote this opinion piece, or this viewpoint, and they highlighted that there's this inherent tension between preventing falls and promoting mobility. So that's kind of the first line that I highlighted. And then they go on to say that the hospital culture has strongly prioritized preventing falls with potential unintended consequences for patient mobility, functional ability, and well-being. Okay, so that's kind of that was sort of the key points that they brought up in this paper. But I think there's a couple of gaps. So first of all, this was, I would consider this an opinion article, and it wasn't based on any empirical data. I think we can all relate to that, taking care of patients, but it wasn't based on data. And I think the question that we were, in our group, we were thinking about, are there strategies that, for example, were that we're doing, particularly, for example, members of the nursing team, to prevent falls that are really truly impacting mobility? So that was our overall question. And I'm going to talk about how we kind of are looking at this. So the first thing I think to consider is who has the potential to ambulate. And I use, when we talk about mobility, obviously there's different levels of mobility, but oftentimes when people are thinking about mobility in the hospital setting, one of the key goals is we kind of want to get patients walking. So just as a to kind of just put a stick in the sand somewhere and kind of identify sort of a mobility level, we're going to focus on ambulation or walking. And this is the graph that I showed you guys earlier, which shows the HLM score on top, which is, again, their performance, what patients actually do, and the AMPAC score on the bottom. This was a patient that I did a consult on to determine whether this patient should be going to inpatient rehabilitation. And what you can see is that actually this patient, they had a lot of impairments initially. So their AMPAC scores were really at the floor, a 6 at the lowest level. And also their mobility scores, were averaging between 1 and 2. So really low level bed mobility. But you can see as that AMPAC score is going up, and I can't really say what's cause and effect here, but we see this trend that as the AMPAC scores or their capability improves, their functional impairments are going down, that their actual mobility, their HLM scores are also going up. So this is something that we have seen just in clinical, seeing patients a lot. So what we did is we did another study. We did a prospective study in 213 mobility sessions. This is with nurses. And the nurses, what they did is they mobilized the patients and they scored the HLM and the AMPAC. And we wanted to see, within the context of this study, did we see this a similar relationship? And indeed we did. So just to orient you to the graph, the x-axis is the HLM score that was scored by the nurse, and on the y-axis is the AMPAC score. And you can see this relationship that as AMPAC scores are higher or their capability is better, that their HLM scores also go up. And that correlation coefficient was 0.65. So again, they're not measuring the exact same thing, but there is definitely, a relationship, and the p-value for this correlation coefficient was statistically significant as well. So one of the key concepts that we have been thinking about is trying to match mobility milestones with their capacity. And the other concept that we have been trying to do is that we want these mobility milestones to be achievable. And again, I think what's important to keep in mind too is that, and I think there's further work to be done in the intensive care unit setting where there's other factors like medical stability and things like that. But in the non-ICU setting, sort of in what we would consider the general med surge floors, neurology, et cetera, where we've done these studies, when we've looked at this data, what we find is that, for example, when we think about a milestone like walking 200 plus feet or an HLM of 8, what we see is that when patients have an AMPAC score of 24, that they're able to achieve that milestone about 90% plus of the time. And that if we looked at a different milestone, like just being able to ambulate, like to be able to take 10 plus steps, that patients are, that nurses can be successful in achieving that milestone when the AMPAC score is, 18 or higher, essentially. And then lastly, like an activity such as transferring a patient to a chair, that they are able to do that when the patient has an AMPAC score of 10 or higher. So using those concepts, what we ended up developing is what we call the Johns Hopkins Mobility Goal Calculator, which essentially aligns their capacity with an actual goal. And the idea is that on a daily basis, a patient, based on their AMPAC score, should have a mobility goal, and we should try our best to try to achieve that. So that's the general concept. And to kind of, again, orient you to the tool and perhaps many of you have seen this on mouse pads. They do live throughout the hospital, but on the sort of to the left here, if you can see my cursor, we see different AMPAC scores, for example, 6 to 7, 8 to 9, or maybe just focus on the 24, for example, on the top there. Their goal for that day would be to walk an 8 or walk 250 feet or more. For example, if their AMPAC scores are 10 to 15, then a goal should be for the patient to move to a chair or a commode. And we actually looked at this. We studied this within the context of a quasi-experimental perspective clinical study. We had a 6-month baseline time period and a 6-month intervention time period. And we actually did it at this hospital. So this was on our neurology unit. We had where the patient populations are actually pretty similar between 12 East and 12 West. So one unit served as the control unit and one unit served as the intervention unit. We did education to staff. We educated particularly members of the nursing team. And then we did an analysis of differences comparisons between time frames as well as the control versus intervention unit. And what we found is that using this tool in the intervention unit compared to the control unit, as well as compared to their baseline, that using this tool resulted in a relative increase in patients meeting their goals. So that increased by 18%, and that was statistically significant, as well as the overall mobility levels that when we looked at the mean HLM scores, it increased from 5.2 to 5.8, and which was a 19% relative increase. And those were all statistically significant. So I wanted to set the foundation because I want to go back to this question about falls. And so hopefully, this idea about matching capacity with goals makes sense. And now we can kind of get back to the falls question. So again, preventing falls in the hospital is really a key quality and safety goal. This is something that's recorded in terms of national databases for nursing care. Levels of falls has, magnet status depends on incidence of falls. There's reimbursement that's based on fall rates and things like that. So something that's really focused on quite a bit. And one of the strategies actually, and a lot of work actually has been done by nursing leaders here at Johns Hopkins, has to do with this idea of fall risk assessment. And so what's really well recognized right now is that a strategy for fall prevention is to have an accessible and up-to-date fall risk information and prevention plan for all providers and patients and families. And this is the tool that we use here at Johns Hopkins. It's called the Fall Risk Assessment, or the JFRAT, and it has these different components. The way that they determined this is that they had there was a group of nurse leaders. They went into the literature and they basically determined what were recognized as important risk points for falls, and in a consensus meeting, they basically came up with this fall risk assessment tool, and they assigned points to it based on what they felt was kind of weighting these based on what they felt was more important. So, for example, they felt like having medications was if somebody had a number of medications that were associated with fall risk drugs, sedated procedures, that would have a higher weight than somebody's age, for example. So that's the tool. If you get scored higher than 13, you're considered high fall risk. And I just wanted to give a little detail. So the mobility component of this tool looks at whether the patient requires assistance or supervision for mobility, whether they have some kind of unsteady gait or they have some kind of visual problems. And so you can get a maximum of 6 points based on those questions. And so the domains are age, fall history, elimination, medications, patient care equipment, mobility, and cognition. Okay, so now let's go back to this question of the potential for ambulation, and this is why it's going to become important for this analysis. So one of the things that we wanted to consider, and so this algorithm should look familiar. I just presented it a few slides ago, is that we expect based on, the research that we've done and so forth, these clinical studies, that patients, if they have an AMPAC score of 18 to 24, that they should be ambulatory. They should have JHHLM scores of 6s, 7s, and 8s for most of the days during their hospitalization. So that's another assumption that we made for this study. So the question that we asked is, if you have a higher fall risk assessment, is that associated with low mobility? So even if you have, for example, a high fall risk, but you have the capability to walk, does that somehow impact your ambulation status? So here we have a patient who's coming into the hospital. And what we looked at a basic level is on admission, or close to admission, they're going to get a JFRAT, or a fall risk assessment. And then they're also going to have an AMPAC, or sort of an assessment about what their capability of moving. And so the question is, what do we expect this patient? Is this patient going to be ambulatory, or are they going to be, predominantly laying in bed or sitting? And this analysis is based on a retrospective analysis of over 48,000 patients. And again, I think that's, one of the benefits of having sort of the systematic approach to measurement, is because we have these measures of fall risk as well as the AMPAC and HLM on all patients. We were able to look for, over a 2-year period at this data retrospectively on non-ICU units to look at this relationship. So let's go back to, our grandfather, or this person that we were kind of talking about before. And the question is, what is the likely outcome? And I wish I could see kind of feedback, but I'm curious. Let me see if I can kind of, what do people think? So if you have a patient who's pretty ambulatory and they're labeled as high fall risk, is this patient likely going to be ambulatory? Are they likely going to be non-ambulatory? What's, even though they at baseline they have that capability, what do people think? I don't know if I can see the chat.
Eric?
Yeah.
Are you asking, if they're high fall risk, once they're in hospital, are they going to be more likely to be bedbound or more likely to be ambulatory? Is that the question?
That's correct.
Okay. I vote for bedbound.
All right. It looks like it's pretty, it looks like it's pretty, at least the consensus is that what I think they agree with you, Dale. All right. Okay. So let's look. Okay, so how do we do this? So what we did is, the first thing is the outcome measure in terms of their ambulatory status, in terms of being bedbound or ambulatory. So the way that we did, we characterize a patient as being ambulatory or not, was that we calculated their median HLM over the hospitalization. So if they were ambulatory, that means that for 50% or more of their hospitalization, they had an HLM score of 6 or higher. So if you looked at this patient, for example, who was in the hospital day 1 through 5, on day 1, they were a 4, but then they were an 8, and then 6, 6, 7. According to this definition, this patient would be considered as an ambulatory patient. So that's the measure that we, and it's it's dichotomous. So that means, was the patient ambulatory or not? So that was our outcome measure. And then we started exploring this relationship between fall risk categories and this outcome measure. So here we're looking at patients labeled as high, moderate, or low fall risk, and this is completely unadjusted, and this is within 48 hours. And what we see is this stepwise progression. So on the y-axis, I'm showing the percentage of patients of ambulatory. So patients who are considered high fall risk within the first 48 hours. Were about, slightly over 20% ambulatory during their hospitalization, compared to patients who were labeled as or categorized as low fall risk, were nearly 60% of the time they were ambulatory. And for the purposes of analysis, we did also look at, the relationship of fall risk within 24 hours, and we see a very similar relationship, but because we did have a lot more missing data within 24 hours for this analysis, we just used the fall risk score at 48 hours, and we felt like we would have a similar interpretation of our results. So in quick summary, fewer patients categorized as high fall risk or moderate fall risk were ambulatory compared to patients with low risk. And then the second question that we wanted to look at is what is the relationship? Sorry, I'm trying to. The Zoom thing is kind of in the middle. I'll try to read through this, but what's the relationship between somebody's mobility potential and their fall risk categories? So what you can focus on are the light blue colors. So here we have three groups of patients who are categorized as low fall risk, moderate fall risk, and high fall risk. And then with each group, we can see patients who have high AMPAC mobility scores. Again, those patients that we expect to be mobile, they have AMPAC scores between 18 and 24. And we can see that patients who are low fall risk, a significant percent of them have high AMPAC mobility scores. But we also see a significant number of people who are labeled as moderate fall risk and high fall risk who also have those high AMPAC mobility scores. And when we look at the total number of patients that that we considered in this analysis, about 60% of patients have the potential to ambulate, who are labeled as or categorized as moderate or high fall risk. And that's over 30,000 patients in the sample. So that's quite a number. So now in terms of our actual statistical analysis, what we did is we went through a process of multivariable modeling. So we considered the outcome measure as non-ambulatory status. And what we wanted to do is we wanted to consider all these other factors that might be explaining their non-ambulatory status. So we considered the different aspects of the JFRAT, so their age, elimination status, equipment, fall history, medication, cognition. We also looked at their AMPAC score, what their ambulatory potential was, their length of stay, their comorbidities. We also looked at just basic demographics like race and gender and so forth. But what the key question that we were asking is, at the end of the day, even when we account for all these factors, the fact that a patient is put into a category of low fall risk, moderate fall risk, or high fall risk, what is that association with that outcome of non-ambulatory status? After we control for all those items. And so this is our main finding that we have from our analysis. And I'm just focusing really on those patients who have that high mobility capability. So again, these are patients who have that AMPAC scores of 18 to 24. When we compare patients who are at high fall risk versus low fall risk, so that's that middle row right there, their odds of being non-ambulatory is slightly over 2. And again, all these p-values are statistically significant, and I showed the 95% confidence interval. So that's suggesting that they're about twice as likely to be non-ambulatory as patient who is low fall risk, even though they have the capability to be ambulatory. And and we saw that relationship also consistent for patients when we compared moderate versus low and even high versus moderate. So we really see that stepwise relationship. So again, in summary, so highly capable patients to ambulate categorized as moderate to high fall risk for falls were about 1.5 to 2 times more likely to be non-ambulatory than those categorized as low fall risk for falls. So the other thing that we've been looking at is what's the mechanism? Like is there something about the impact of fall prevention interventions on mobility? And one of the things that members of the nursing team do is that when they score the JFRAT, they also select some interventions that they want to implement for the patient, and that's part of their workflow. And there's a number of those interventions that impact mobility. So those are things like bed and chair alarms, restraints, sitters, etc. And what we looked at is on a daily basis, we looked at all the interventions that could potentially impact somebody's mobility, and we basically quantified them. Did they have one intervention per day, or maybe they got one intervention every few days, and so forth. And so this table, what it's showing is we're looking at patients with different JFRAT risks. So we have at the top, we have patients with low risk, moderate risk, and high risk. And then patients who are ambulatory and non-ambulatory. And what this table is showing is basically the rate at which mobility of interventions are being selected by nursing to try to alleviate the patient's fall risk. So at, for patients with low fall risk, very essentially no interventions that potentially impact mobility are being selected by nurses. For patients that are at moderate fall risk, there are a few interventions that are being selected by nursing, but particularly when we see that patients who are non-ambulatory, they're getting more interventions that impact their mobility. And then for patients who are at high fall risk, first of all, we're seeing lots of interventions being selected by nursing that could impact mobility, but particularly for patients who are non-ambulatory, we see the highest rates being selected for these patients. So this could be a possible explanation about why patients are less ambulatory, and these differences were also statistically significant, and is something that we're currently working on writing up for publication. So in summary, having more interventions that impact mobility is associated with lower mobility. And patients categorized as high fall risk have more interventions that can impact patient mobility. That's I would say, kind of the big theme of what we're seeing with this type of analysis. So one of the questions that we're asking is that, can patients, depending if they have moderate or high fall risk, can they be mobilized safely to achieve mobility goals? And so we actually have a study right now. This is on a surgery unit. We have 185 mobility sessions now with very engaged members of the nursing team, and they've been mobilizing patients using the goal calculator, which I showed before. And we've been looking at different barriers to mobility, why patients can't achieve their goals, et cetera. And one of the things that we've been keeping track of is what patients' fall risk is. So in this case here, this is mobility events where patients were labeled as moderate fall risk. And in terms of the frequency that patients actually met their mobility goal, we can see that these members of the nursing team were able to achieve their goal. And again, this is during routine care, but these were considered, I would consider them champions of mobility on their unit. But they were able to achieve that 97% of the time, even though the patient was labeled as moderate. And even for patients who are labeled as high fall risk, when they use that goal calculator, they were able to achieve the goal at 93%. So, a little bit less, but definitely, to a really significant level. So why is this important? So we think that this concept of using somebody's capability and thinking about that within the context of somebody's fall risk is important. And so members of the AMP team, and I'll give a shout out, for example, to Annette Leveza, who's been working with the whole health system in developing a policy for fall assessment, prevention, and management policy. But I just wanted to highlight one of the key parts of that policy now that's now my understanding is either pretty close to being implemented or anyway, it's very close, I think is my understanding. But is this idea to set mobility goals and address barriers impacting ability to achieve those mobility goals. So this idea of setting mobility goals has actually made its way into a policy, which I think is really an important way of addressing the immobility harm in relation to patients with fall risk. The other thing that I think is important to keep in mind that's relevant for AMP is that we talk about promoting mobility, but I think what's also important is this concept of safe mobility. And so something that we've been also another group that we've been partnering really closely with is the safe patient handling group. And so hopefully, this algorithm is looking really familiar to you guys now. You can see the AMPAC score on the left and these mobility goals. But in addition to that, we're also suggesting different types of equipment that can be used on the patient to really help facilitate that, because we also not only want to avoid patient injury, but we also want to avoid staff injury. So that's another goal that we've been working on related to all this work. And I think the other point, why this is important, this is, some more recent analysis that we've been looking at, is just the question of is who are the patients who are at risk of falling? The way that the JFRAT is designed is that essentially you get penalized if you have more mobility impairments. You kind of get penalized, and the assumption is that you would have a higher fall risk. But when we look at the relationship between a measure like the AMPAC score, which is here on the x-axis, and the probability of falling, we actually see a different relationship. We see this inverse U relationship. And this is data, again, from over 40,000 patients of fallers and non-fallers. And what it seems like is really that there's this area where patients are at the highest risk of falling that are sort of in the middle. So if you're at the high end, if your AMPAC score is really high, you tend to have less injurious falls. And also patients at the really low end, they also tend to have injurious falls. So just giving this feedback actually to nursing leadership has been really helpful for them to understand about who are patients that we might need to think about, for example, using equipment or so forth, different strategies to mobilize them safely. And I think in terms of this overall goal of promoting activity and mobility promotion, if we kind of go back to this, our grandfather or this elderly person that I kind of presented in this presentation, a lot of patients actually when they come to the hospital, have this ability to ambulate or to be mobile, but because of immobility, they're kind of coming down, lower in this curve, but through this process of immobility, particularly over, let's say, a prolonged hospitalization, we might actually be moving them up this risk curve. And that's a really an important reason why we need to be paying attention to that, because we don't want them to be living high on this curve where they might be at the highest risk for harm related to fall. So just in conclusion, and then I'll have a little bit of time for questions. Just wanted to kind of highlight some goals for the future in terms of our work. This is obviously related to falls work, but I think as our AMP group, what we're really trying to do is we're trying to think about how function fits into lots of different goals of the hospital setting. So really a core idea is at the center of every care plan for a patient. That in every handoff, activity and mobility needs to be prioritized. We've been working with all these different hospital systems to adopt a system-wide interdisciplinary functional assessment strategy, and we advocate for the tools that that I presented today. We really want these tools and AMP, these initiatives, to really to be a patient's centered safety quality priority, no different than these other types of harms that we often hear about, like hand hygiene or medication reconciliation. And as I mentioned before, we really look for opportunities to kind of integrate into all these different initiatives, because mobility, for example, as like in the first one, surgical pathways, mobility is really important for all these different aspects, or function, I should say, and activity is really important for all these different aspects of improving patient outcomes. So the better that we can integrate ourselves into the workflows, into strategic priorities, et cetera, I think we can really have a positive impact on patient outcomes. And then, we continue to deploy our tools across the health system. We also are partnering with external groups. So we've been partnering with, for example, with New York Age-Friendly Health Systems. You'll probably hear more about the LEARN system. We have actually a LEARN scholar who's right now at Hopkins looking at the relationship between cognition and some of these outcomes. We have some projects also at Intermountain and Boston Medical Center. And we also have a multi-center study looking at implementation of AMP at these 3 hospitals in Delaware, Colorado, and Louisiana. So I think more to come about also from an implementation science aspect about how we really deploy AMP and culture change across different institutions beyond Johns Hopkins. And then lastly, we're also looking to deploy some of these tools to other partners such as the VA and the DoD. So I think lots of exciting things to come in terms of AMP. So here's a link to our website. We do have a campaign for Everybody Moves, which is an effort really internationally to try to bring awareness to reduce the immobility harm. And I think with that, I'll end the presentation and take any questions.
Eric, I think there's a question from Megan in the chat.
Okay.
Hey, Eric, I can also just follow up with my voice. First of all, I just wanted to thank you and Annette and everybody who's been working on AMP. It's sort of staggering to think about how much harm reduction has happened here at Hopkins and multiple other places where you guys are doing all this training. It is just a phenomenal accomplishment. And the question was, as AMP evolves and you guys have sort of progression in your goals, I'm wondering if there's a plan for a workflow for people who are designated as at baseline when they're in acute care. So for example, I'm thinking of folks who have spinal cord injuries or like a muscular dystrophy, and these folks might have been active in their own ways at home, but when they come to hospital are designated kind of at baseline, and then the diffusion for keeping them there's a diffusion of responsibility for keeping those folks active. Yeah. That's an anecdotal observation, and I could also be wrong about that.
Yeah, I don't know if Annette or Samia are on this talk, because I think that's just from an operational standpoint. I think they would probably be best, and so I'm happy to follow up with that. I would say from a research perspective, I think we've been focusing on kind of the broad patient population, the 70%, and trying to make an impact, kind of trying to move the needle forward. And I definitely agree that there's patients, I think, who are, perhaps at more risk or more vulnerable, who need a rehab plan for when they're in the hospital, and how that's being implemented in particular. I think that's something that I would love to hear, our acute care therapy team address.
Eric, I'm going to jump in. This is Dale. With a couple of comments, primarily because you said that you're going to go on the road with this. And if I was a skeptical audience member, I had maybe a couple of questions to ask. But the big picture is, I think this is just absolutely fantastic. I think your presentation is very motivating, really important, a huge body of work. So I'm just going to nitpick about a couple of smaller things. Thank you. So one thing I wonder about is, I presume that you got the data on bed, chair alarms, restraints, and sitter use from Epic. And if yes, just how accurate are those data when you're actually doing modeling with them?
So these are, it's part of so it's actually not based, like it's not the device, it's what the nurse selects. So part of, in the flow sheet that the nurse selects as part of their workflow when they're completing their fall risk assessment, is that they actually have to select interventions that they will carry out as part of their care plan. to try to mitigate the fall risk. And that's the data that we were collecting for that analysis.
Okay, great. So that's really helpful. Naively, I wasn't sure how those data came about.
Mm-hmm.
I think for sake of your presentation, you could gloss over that. The other thing that I wonder about from a statistical point of view is you have a multivariable model that I think includes, I think it's called the HFRAT score, the fall risk score, and then also includes the components of the fall risk score. And I recognize what you're trying to do. I know the research question you're trying to tease out, it sends off a kind of an amber flag in my head from a statistical point of view regarding, having a composite score and then all the components of the composite score in the same regression model. The easy question is there multicollinearity? And presumably that was tested for, and there's no significant multicollinearity. But then the second question is, I don't know, is there any sort of concern in terms of the statistical model when it's designed like that?
Yeah. Yeah. So Elizabeth well, and this is something that we talked about at length. I know that we have tried, we definitely, we felt that it was important that in order to get to the category, the fall risk category, we felt like it was still these components were still important beyond the categorization, and we did look at things like the multicollinearity issue, which was not an issue. So that was and we also did sensitivity analysis because even sort of the presence or absence of these different impairments or the actual raw score. So we looked at it in a bunch of different ways, and essentially our results were consistent and similar, and so I think that was a key reason about why we felt confident that the results that we were getting were accurate or true.
Great. And I think I don't imagine that probably wouldn't come up in a presentation. It might come up in peer review of a paper. And I presume that you had thoughtfully talked about that. And that sounds great. Thank you so much.
Yeah, of course. Thank you. Thank you, Dale, for those comments.
So I think our time is technically up, but I wanted to say again, thank you, Dr. Hoyer, for presenting your research. I get very excited to see all the work we're doing just to get our patients moving. And I know that the group on this call is very invested and excited about that as well. So again, thank you for your work and for sharing. And I'm sure we look forward to hearing more about how this progresses. So everybody, I hope you learned a little something. I'm sure Dr. Hoyer will be happy to take questions via email or other ways of messaging if you have more. And I hope everyone has a great day.
Thanks, everyone. Have a nice Wednesday.